Hello and welcome to today's Center for Healthcare Strategies webinar on incorporating community voices to improve complex care, made possible with support from the Robert Wood Johnson Foundation and co-sponsored by the Better Care Playbook. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated Q&A session after each of today's presentations. You may submit a question anytime online by clicking on the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Rachel Davis, Director at the Center for Healthcare Strategies.
Great. Thank you so much, Travis, and welcome everybody. Thanks so much for taking the time to join us for today's webinar. I also want to thank the Robert Wood Johnson Foundation for making this webinar possible. As you can see from today's agenda here, we've got a terrific set of presentations lined up. We'll start with a brief overview on why this topic is so important for complex care. And then we'll hear from presenters from Maimonides Medical Center in Brooklyn, New York, as well as the Roots Community Health Center in Oakland, California, sharing some of the terrific work that they're leading. As Travis mentioned, there'll be a moderated Q&A after each of these presentations, so we'll have an opportunity to hear questions from the audience then. Whoops, sorry about that. I want to take a minute to introduce today's presenters. My name is Rachel Davis. I'm the Director of Complex Care at the Center for Healthcare Strategies. I'm joined by Susan Mendy, Senior Program Officer at the Robert Wood Johnson Foundation, Sherry Sukoff, Vice President for Policy and Strategy, and Okenfe Liberty, Senior Manager for Community Engagement at Maimonides Medical Center, and Dr. Noha Abolada, the Chief Executive Officer at the Roots Community Health Center. For those of you who may not be familiar with CHCS, we were established in 1995 through a major grant from the Robert Wood Johnson Foundation to improve the underpinnings of the nation's healthcare safety net. Today, our mission is to support innovations in care delivery and improve the health of low-income Americans, particularly those with complex and high-cost needs. To achieve our mission, we work with states, health plans, providers, community-based organizations, and federal policymakers. And our work focuses on three priority areas: integrating services for people with complex needs, advancing delivery system and payment reform, and building Medicaid and cross-sector leadership capacity. We're also really excited to be co-sponsoring today's webinar with the Better Care Playbook. If you're not already familiar with this resource, I encourage you to check it out. It's an online resource center featuring the latest knowledge on evidence-based and promising practices for people with complex health and social needs. Its library is continually updated, and it's got lots of practical tools that are designed to help health system leaders, plans, policymakers, and other stakeholders improve care for high-need, high-cost populations. The site is coordinated by CHCS through support from 6 national healthcare foundations: the Commonwealth Fund, the John A. Hartford Foundation, Milbank Memorial Fund, Peterson Center on Healthcare, RWJF, and the SCAN Foundation. You can visit the Playbook's website at bettercareplaybook.org. And before making a few brief remarks on the importance of the topic of community engagement, I do want to turn it over to Susan Mendy from RWJF to comment on the Foundation's interest in this topic and commitment to it. So Susan, I'll turn it over to you.
Thanks, Rachel, and good afternoon, everybody, or good morning to those who may be calling from a different time zone. I think that many of us on the webinar know that unfortunately efforts that are led by healthcare systems are very often disconnected from the communities in which their patients live. And we find that they're particularly disconnected from people who have experienced trauma or people who face really complex intertwining health and unaddressed social needs, such as lack of housing, poverty, or living with violence. And, you know, in order to really meet those needs and to identify the needs, what their patients and communities see as the most pressing needs, health systems really need to be informed by these communities, and they need to align with community partners, figure out what their priorities are, certainly leverage so many of the resources and leadership in the community, and also work with the community on implementing and monitoring impact of their different approaches. And we know we really cannot hope to address equity or make real impacts on people or communities' lives unless we start this work, unless we start talking and planning and listening and designing and partnering with patients, with people, and with communities. So I look forward today to listening to two pioneer organizations in this work, and I will turn it back over to Rachel.
Wonderful. Thank you, Susan. So as Susan alluded to, there really clearly is a growing recognition that healthcare systems need to focus on engaging the community to better understand its needs and the importance of meaningfully developing partnerships to address them, and that these pieces are core to being able to effectively serve their populations, particularly those with complex needs. Forging these relationships can help healthcare systems better understand the community's needs and wants and the barriers that they are experiencing to achieve health, as opposed to having healthcare systems assume that they understand what these are. It allows healthcare systems to benefit from and leverage the myriad valuable local resources and leaders that are already in place in these communities and can help guide and inform healthcare efforts. And they can really help to ensure that implementation is both lasting and more effective, because it can help with securing buy-in from the ground up at the grassroots level. That being said, as I imagine many of you on the line today know, doing this work isn't easy. There's a lot of challenges to it, including power imbalances that are just inherent when we're talking about healthcare systems with multi-million-dollar operating budgets compared to grassroots community organizations and local community members. There are clearly and oftentimes pretty stark differences in culture between the community and healthcare, and differences in business models, just to name a few. So to better understand the strategies for addressing these challenges and approaches for how to do this work effectively, CHCS has had the wonderful opportunity to explore these questions through a number of different projects, including the Community Partnership Pilot. And this is a project that has been funded by the Robert Wood Johnson Foundation, where CHCS has worked to support 2 sites in 18-month pilots that are really focused on uncovering best practices for how healthcare systems can build and grow community partnerships. The goal of this project is to better understand how healthcare systems can gather and integrate consumer input in meaningful ways, how they can hear and solicit from the community what the community's own priorities are, exploring strategies for how to co-design and co-implement some of these efforts to address the barriers that the communities are identifying, and through all of that work, also thinking about how to collectively address the equity challenges that we know our communities and healthcare systems are trying to tackle. The 2 pilot sites that we're working with on this project are the Whole Person Care Program in Los Angeles, which is focused on creating a countywide reentry advisory collaborative that will be comprised of individuals who are involved or have involvement in the criminal justice system. And the goal here is to help the county better understand how to meet the needs of the population that has criminal justice involvement and better support them. And the second pilot site is Hennepin Healthcare in Minneapolis, which is partnering with its foreign-born Somali population to identify and address barriers to accessing mental health services, because this is a population that underutilizes these services compared to other groups in Minneapolis. We've already had a chance to hit on a number of really wonderful learnings from these projects, and I won't belabor them because I think a lot of the topics that are listed on this slide are going to be ones that the Maimonides and Roots folks will be touching on in their presentations. But I think some of the emerging themes that are just really jumping out to us at CHCS are how important it is to have transparency and be clear with expectation setting on the part of how the healthcare system intends to partner and use this information. There's clearly been a sense that there's no way to shortcut the trust building process. It just requires time and commitment. As you'll hear today during our presentations, there's a number of different ways that healthcare systems can approach collaboration, and that it's really wonderful. It's a wonderful opportunity for healthcare systems to think through where there are existing relationships and efforts and leadership that the healthcare systems can align themselves with in order to bolster their community partnership efforts. We've put out a number of blogs already on learnings from this project, and one of them is highlighted in the slide here around best practices for convening consumer advisory boards. So hopefully between today's presentation and some of the resources that we have on our website, those of you who are listening in will come away with some really great insights for how to take these approaches into your own work. So with that, I think I will turn it over to Sherry and Okemfe at Maimonides.
Thank you, Rachel. Hi, everyone. Okemfe and I are excited to be talking to you all today about one of our favorite topics, participatory action research and how it fits into our overall community engagement strategy. So just to give some background on Brooklyn. Oh, went too far, sorry. So just to put things in context, Brooklyn has over 2.7 million residents, so on its own would be the third or fourth largest city in the U.S., so a large community when we speak about community engagement. Of that 2.7 million, over half of those residents are either on Medicaid or are uninsured. There's a lot of diversity in cultures, languages spoken, and we have a number of distressed hospitals and providers throughout the borough. So just to put that to scale, it's 33, a third of the New York City's total Medicaid beneficiaries are in Brooklyn, and 2% of the country's Medicaid beneficiaries are in Brooklyn. So big population that we're working with here with a number of challenges. So compared to the rest of the country, we have more residents living in poverty, more unemployed, more household income going to rent, but fewer uninsured residents. So about 10% fewer uninsured residents compared to the national average, but a lot of other challenges at play. Maimonides Medical Center is the hospital that we are speaking to you from today. We're the largest hospital in Brooklyn, serving as the borough's tertiary care hub. Over 82% of our patients are on Medicare or Medicaid. So we participate in lots of community benefits and investments and have a long history of leadership in population health. So Okemfe and I are both part of our Department of Population Health, and the work that we'll be discussing today is all mostly happening within this department. So a lot of the work that we've done over the last 5 years in particular has been under the auspices of Community Care of Brooklyn, which is a very, very large network of Brooklyn health and social service providers who are working together on DSRIP, which is a major Medicaid redesign effort that's been going on in New York State for the past 5 years. So this large network, Community Care of Brooklyn, has over 1,000 participant organizations. You can see the types on the screen, but ranges from hospitals, FQHCs, 70 and growing community-based organizations, unions, managed care plans, anyone and anything that sort of touches health or the social determinants of health is part of this network. Together, we are responsible for about 600,000 Medicaid beneficiaries, so that's about half of the population in Brooklyn. And the overarching goal of this Medicaid redesign effort was to create an integrated delivery system, better coordinate and align care, and really quickly, when you start having those conversations about better coordinating and aligning care for the Medicaid population in particular, you get into the social determinants of health. So working with our CBO partners to address the social determinants of health quickly became an early priority of ours. And PAR, Participatory Action Research, which Okenfe will describe in a minute, is really the best example we have of a project that brought together this diverse set of participant organizations on a coordinated effort that really involved the community, addressed many of the challenges or started to address many of the challenges that Rachel described, but is a really great example of an effective partnership and a way that we have been able to shift that power dynamic from our big hospital and this big expensive program that we've been working on, this well-funded program, to really incorporate the voice of the community into many of the decisions and many of the ways that we've shared these resources and used these resources to really address many of these challenges. So with that, I'll turn it over to Okenfe.
Thank you, Shari. So on the community engagement front, for us, with everything that Shari has said was, where do you even begin to work with these networks of organizations, CBOs, social service providers, with their various needs and the various responsibilities that comes with that. And so for us, the approach that we ultimately took was that of PAR, Participatory Action Research. In essence, because the PAR helps you to understand that complex social, economic, and environmental problems basically cannot be addressed through top-down needs-based development approaches. As some of you are aware, normally other researchers that are not necessarily versed in PAR, they have these highly paid consultants. They come into the communities and they tell community, hey, we know better than you, and we can fix all your problems. But PAR takes a little bit of step away from that because with the PAR, it includes residents in the research process, which is pretty much going to help drive changes in their own communities. He also acknowledges local stakeholders' personal experiences as valid and critical in identifying community assets and implementing action plans. Because this is their neighborhood. They know their neighborhood better than anybody else, and it's always better to pretty much work with them. And lastly, it shifts the power balance by changing who determines needs and solutions, and more importantly, they are part of those power dynamics. And so when we started this project, we started in 2016, trying to build a deeper understanding of the social determinants of cardiovascular health in two dangerously afflicted communities in Brooklyn. And the first published report in these two communities indicated that successful engagement and organizing efforts must address head-on the strong lack of trust between the community and the local healthcare system. And the two communities that we'll touch a little bit on the next slide was Brownsville and East New York. And in terms of including the overall community members and other local stakeholders, we have our community action and advocacy work group, which I believe as of yesterday, it is approximately 100 plus individuals and organizations. And to their credit, that has been meeting every 6 weeks for the past 4 years. And in between, having a biweekly conference call as well within these past 4 years. And so the first project we did was in 2016. That was in Brownsville and East New York. The second one was in 2017, which was a partnership with Interfaith Medical Center and
New York Community Trust.
New York Community Trust, yes. That was in Bed-Stuy, Crown Heights, and East New York. In 2018, we did another one in Canarsie, Flatlands, Flatbush, East New York, and Starter City. And the last one, which is almost complete, was done in Southwest Brooklyn, the neighborhoods of Sunset Park, Bay Ridge, and Borough Park. And if you look at the map to your right, between 2016 and 2017, you see that we're almost our way to covering the entire Brooklyn.
And just to say a little about the PAR process, so each year as we've sort of moved into different neighborhoods, we've worked with local grad schools, local colleges, and then we identify high schools in the neighborhoods and work with the principals in those high schools to identify students who can be part of the research project for the summer. So it's led by student researchers who work together to learn about participatory action research, learn about human subject research, study the neighborhood, map the neighborhoods, and then design a survey, sort of come up with a research question and design a survey. And then in the last 2-3 weeks of the summer, they go out and survey the neighborhood and survey over 1,000 people to ask those questions and to identify what's really driving the poor health outcomes in that neighborhood.
And just one additional thing. Prior to the start of each PAR, we do have a convening of elected officials and CBOs that are in those particular neighborhoods. Because again, what we want to do is that we want them involved in this research process from early on in the process all the way to the end of the process. And in terms of the PAR outcomes so far, we've surveyed about 3,500 plus community members, 150 plus high school, college, graduate students who've all been trained in participatory action research. We have 75 plus community endorsed recommendations, from food justice to affordable housing to building local organizing capacity, leveraging anchor institutional resources and whatnot. And lastly, about 700 plus community assets has been identified. And what are some of the key findings? So with our first PAR in Brownsville and East New York, the two key findings from that were food justice and nutrition and physical activities. Then our second PAR in Bedford-Stuyvesant, Crown Heights, and Flatbush, some of the key findings had to do with gentrification, changes that were going on in the neighborhoods, and affordable housing. Also economic development and mobility, sustainable civic infrastructures, and also how do you begin to, again, redesign the whole healthcare system and how it affects people that are residents in those neighborhoods. Part 3, Canarsie, Flatbush, and Flatlands, health and resources, especially looking at issues surrounding mental health. Again, affordable housing, which has literally been one of the constant themes that has come out of this pause. Education and youth development, and lastly, public safety. And as always with this pause and with any research work that you do, one of the things that we wanted to avoid was that doing a research and then when you have the report is collecting dust in somebody's desk but we understood the kind of neighborhoods that we are working in, and we understood the need for some quick and specific result-oriented actions that were going to be coming up. And so one of the first things that we did was to partner with the mayor's office on a project called Healthy Savings, which was basically to support access to fresh foods in these neighborhoods. And the second one we did was farm to institution, and that was a partnership with one of the biggest CBO in Brooklyn called Restoration Plaza, to basically begin the process of developing a farm to institution initiative in partnership with the organization that I just mentioned. And we worked also on hydroponic farms, and I think one of the interesting things is that as a hospital system, getting involved in the issues of hydroponic farm, which in a million years, you've never seen that a hospital system would be involved in that. So we partnered with an organization named Teams for Food Justice and Brooklyn Sprout to begin to figure out a way we can increase access to healthy food and also develop a community-owned hydroponic businesses. And lastly, we also partnered with an organization called Fun for Kids, which is providing a year-round fitness and nutrition education in elementary schools in Brownsville and East New York. And with Fun for Kids, they are working with over 400 kids in these two participating schools. I'm going to hand over to Shari to talk a little bit.
Sure. So we have lots of recommendations. You can see they're pretty far-reaching. And we have used them to really drive a lot of the work we've done. So instead of us just sort of looking at data, publicly available data or research, other research data and seeing what the problems were and coming up with programs to try to address them, we really have used PAR as a driving force to determine how we should be working together. And we've been working with the community really hand in hand in implementing many of these programs, designing and implementing many of these programs. So Okempe went through a couple of specific initiatives that we've been able to fund coming out of some of our PAR work. These are more ongoing, larger scale movements that are also coming out of the PAR work. So Brooklyn Communities Collaborative is a new nonprofit that is formally uniting a lot of the members of our community action and advocacy work group and many of the groups who have been the driving force behind PAR to work together to strengthen health, wealth, and leadership in Brooklyn communities, really leveraging the power of the anchors, so meaning the hospital anchors, the university anchors, so big places in Brooklyn that employ a lot of people and buy a lot of things, and figuring out how we can use that in partnership with our communities to really reinvest in Brooklyn. Reclaiming Our Health is another initiative that we're working on to address mental health stigma in Arab, Middle Eastern, Muslim, and Southeast Asian populations through culturally sensitive education and community mobilization. That's been another example of really working in close partnership with a community organization, a few community organizations, and designing a program along with them to make sure that it is one that can stick and be successful. And the East Brooklyn Call to Action is a partnership that we have with the city's Department of Health and Mental Hygiene, many of our existing partners in labor, community-based organizations, to mobilize community members really around the recommendations of the PAR. They sort of have used that as a way to say we need to mobilize, we need to be able to address these pretty big issues. Health and housing is not something that's going to be solved with one initiative. It's going to take a lot. But as I said, the PAR has really been a driving force behind making this, forming this partnership, building this trust, and empowering the community. Along with, many of the recommendations that have come out of this and the programs that are directly tied to this, we also are raising a generation of community advocates. We have 150 and growing PAR alumni. Students are part of a PAR alumni network, that are engaging with their communities, working with local institutions. They receive congressional commendations from local legislators who are really involved and have been really involved in the process as it's been moving forward. And they really connect students to the broad world of healthcare, social services, human services, everything that's out there. They, come to our meetings with these 100+ people and organizations. They get exposed to a lot of different ideas of possible career paths. We provide mentorship opportunities, and for many of the students, they have said that this has been a really transformative experience in their lives, and that's been really a wonderful component of this as well. So wrapping up, and then before moving to Q&A, some of our lessons learned, and there have been many over the years, is really to trust local knowledge. Don't underestimate the value of communities. Make sure that community voices are included at the decision-making table. It's not enough to say we're going to do research with you. We then have to be able to say we're going to then take the recommendations and sit together and figure out how we're going to address them. This all requires a lot of time, patience, and commitment, and I think that's been key to our success is everyone's commitment, belief in this process, and commitment to stay at the table. Be open to new ideas with lots of different people coming from lots of different backgrounds and different worlds. There's a lot of different ways to do things, and everyone needs to listen to each other. And using a consensus-based approach to decision-making has been very helpful in aligning all of these various sectors together. So I think with that, we will be happy to answer whatever questions you have.
That's great. Thank you so much, Shari and Liberté, and just congratulations again on this really exciting work. I do want to put in a plug that we had the opportunity to do an in-depth profile of the work that Maimonides is talking about. So for folks who are interested in learning more about this, please check out our website. There's a really nice in-depth profile describing this work that recently got posted. So we do have a couple questions that have come in from audience members, and I want to encourage folks who are on the line, if you have questions, to use the online platform to ask those questions. And I guess let's start with actually a question that's kind of top of mind for me, which is I'm curious why you guys were drawn to participatory action research as the modality for engaging the community. What was it about PAR that you felt like was the right fit for achieving your goals here?
I think when we started this process and we had all of these different groups coming together as part of the Community Care of Brooklyn network, and we were tasked with this really big goal of sort of bringing everyone together and creating an integrated delivery system and addressing the social determinants of health. And, there was a lot to do and a lot of people to do it with. And I think there was a recognition that the ways that health systems and community groups and various stakeholders had been working together in the past weren't working. We started this work with a community health needs assessment, which identified sort of all of the problems that everyone knows exists and that all of us had sort of seen before. And I think there was a recognition that the traditional data, health research and traditional social service research wasn't really getting at what the community, it wasn't incorporating the community voice in a way that we know we needed to do if we were going to be successful. And I think it's been successful both in identifying community priorities, but also really in bringing the community to the table and fostering that partnership that has been so critical to our success. So I think when we heard about it from then Professor Phil Thompson at MIT, who is now deputy mayor here in New York City, it seemed like a really good way to get started in this work in Brownsville and East New York, and it has sort of taken on a life of its own because it has been so successful in what we sort of hoped it would be.
That's great. Thanks, Shari. Okay, a bunch of other questions are coming in. So we've had a couple questions from folks wondering if you guys could provide some more specifics about how you recruited community members or started engaging the community members into both the decision-making process, the asset identification process, and into the, I think into helping to lead the PAR work itself.
Sure. So we worked with a couple of the local colleges here in Brooklyn, Medgar Evers College, Brooklyn College, some grad schools. Those were a little bit further reaching in New York City and other places. But when we identified the neighborhoods that we were going to be working in, we worked with Medgar Evers and Brooklyn College to identify students from those neighborhoods. So we sort of have key faculty partners that we work with at both of those colleges. Oh, and Kingsborough Community College. So those three. And they helped to identify students from those neighborhoods. We then reached out to the high schools in those neighborhoods and worked with the principals to identify people who are interested in doing work like this. So we were able to have the sort of majority of our student researchers be people who lived in the communities that we were surveying. So that's how that's how PAR kind of built into the process that community voice is represented in every step.
And for the CBOs, what we did was that in each of these neighborhoods, we actually went out and did some research on all the CBOs that were in these neighborhoods. Be it 50 CBOs that are working in each of these neighborhoods, 100. So we took that kind of information. We reached out to all of them, and we invited them to a meeting to talk to them about the work that we're trying to do. And then we also reached out to the elected officials that also represent these neighborhoods and held a legislative briefing breakfast with the elected officials to also invite them officially to participate in the program, so that from the schools, the high schools, the universities, the CBOs, the elected officials, the social services organizations, the hospitals, so that everyone is basically well included and making sure that everybody's on the same page.
That's great. One of the things that really struck me from the profile is that I think there's one of the students actually is talking about her experience going out and canvassing the community members with these surveys and hearing from the community, kind of like, people come and ask us these questions all the time and then like leave, or we don't know what happens with the responses that we're giving you. And it felt like that was really impactful for the student to hear. And so I think there's an element also, having the students be from the community where they, it was really important to them to be thoughtful about how to use this information in a sustainable way and be transparent and be able to reflect back to the community how this information was being used. Is that a fair reflection back to you guys about some of the experience of the students and the feedback from the community and how they work to try and get community buy-in as well?
Sure. So at the end of every PAR project, we hold a community report back session where we invite folks in the community, the students that participated. We also invite their parents, the schools, for the students to report back to the community and for the community to give us a feedback that in essence will also be included in the report. So it's usually about a 2-hour program where the community gets to hear from the students, they get to hear from the leadership, and then they also get first some understanding of the research recommendations, and then they're also able to include their own input in terms of what they think about some of these recommendations. And I think what has been constant across the board is the fact that the work that the students do throughout the summer that is reflected in the reports, in essence, that's what the community members, when they come, say, look, this is basically what we've been experiencing.
That's great. There's another question here sort of along these lines of, in terms of your strategy for recruiting high school students, did you guys explore giving them credits to satisfy graduation volunteer service requirements, or was there anything sort of formally linked into compensating them for their work on this project?
So the students are all paid to do the work, so it's a sort of competitive high school pay and college, so it is a paid job for the summer.
That's great. I'm sure it makes it all the more compelling. So there was a question that came in around whether or not you guys feel like you came across any strategies through this project for holding groups like the Brooklyn Community Collective over the long term. It sounds like that group has been convening for an impressively long time. So curious if you guys have any recommendations for how to sustain those kinds of convenings for long duration.
You know, I think what's kept people together in this effort is that everyone is very bought into the work and really committed to seeing the, recommendations play out and improvements made. So people are dedicated to the overarching goal. And at this point, there's always work to do that people are interested in doing and sort of committed to do. So I think it takes time, and I think at the beginning of the 5 years, there was a lot of tension between the health systems who were receiving these large Medicaid funds and the CBOs who, were not getting them. And I think because we have really worked in partnership over the time, we have, like I said, created that trust and created those relationships. So now, people are really bought into this. They're really committed to it. They see that they have a voice, and they understand that they're a key part of this process. So I think it definitely takes time to build those relationships and build that trust. But now that, I think once you have it, as long as you continue working towards the same shared goal, you can keep people at the table.
Right, and also there is also this recognition that we are all in this together, from the schools to the hospitals to the labor unions to the CBOs. Everyone has basically recognized that in order to begin to change some of these health outcomes in these communities, and also moving towards the finish line, we've all got to work together, and that recognition is there. And lastly, I think the issue of having a consensus-based approach to decision-making, whereby it's not just one person that's making the decision, but everybody's making the decision together, because it's something that's going to affect everyone. So I think that has also been helpful.
Yeah. So, okay, that's actually a perfect segue into another question that we got, which is if you guys could provide a little bit more of the specifics on how that consensus decision-making process looked for you guys, and how you use that to address some of the power dynamic imbalances that were mentioned throughout this presentation.
Sure. So we, in setting up the governance for Community Care of Brooklyn, this network, we have used a consensus-based decision-making approach, which really means that you need, I don't remember the number, 70% of people to agree on anything to move it forward. We've actually never really had a dissenting vote this whole time. I think we work really carefully with our partners to make sure that people are involved in all aspects of the program planning, of implementation, so that there doesn't really get to a point where there's a contentious vote. Maimonides is fiduciary of the network of Community Care of Brooklyn and does have sort of overall veto power, but we've never used it. And we always say we never would, because I think if we get to that point, then the partnership is effectively over. So there are certainly things that have taken more time to get through and to come to a solution. And like I said, things take a lot of time and a lot of patience, but we have really just worked carefully with partners to make sure that we could get to a place where we are, for the most part, aligned and in agreement about how to move forward.
That's great. So we've gotten a couple of questions about how you guys measure this work. Do you want to speak to that a little bit?
So in terms of?
I think in terms of understanding the impact, and then also sort of understanding the long-term health progress. If you guys are able to sort of track how you think that these efforts might be impacting any aspects of either the community outcome, health outcomes, or relationships with the community. I don't know, any of the spectrums that you guys might be thinking about outcomes for this work.
Sure. I mean, I think for now, it has been, we sort of know that it's been a really sort of galvanizing process to bring people together and keep them together. And we have, congressional reps who are interested because they've seen that some of the work has led to some state interest and state funding, and the city's involved. And I think it sort of brought a lot of people together. So I think from that, we sort of know that it's working from that perspective. This is a piece of a whole larger initiative that we're working on here around, health outcomes and health data, and we're measured by the state, and we on over decreasing hospitalizations and lots of specific clinical outcomes. We are monitoring all of those things sort of as it relates to the more clinical work we do, and this, which we see as a piece of it. So I think we're definitely monitoring the long-term impact that all of this work together has. Many of the specific initiatives that have come out of PAR are a little too new at this point to sort of have specific data points to share, but we are, of course, measuring everything and monitoring everything that we're doing, and we'll report back.
Right, and just to add one quick piece, of course we have our whole data analytics team and working on this measurement and whatnot, but I think when you on the community engagement front and dealing with CBOs and whatnot, sometimes I think some of the disconnect has always been, how do you actually quantify the work that CBOs do in their communities? How do you measure some of these things that sometimes are not really measurable? But with what we've been doing here at CCB, we'll be trying to figure out some ways around this initiative that we can actually account for the progress and changing health outcomes in Brooklyn.
Mm-hmm. Yeah, I think that's such an important point, Okenfe, that, some of the conversation I think that's emerging through this increasing recognition of the importance of partnering with the community is that maybe we need to be thinking about some different measures to really understand what this work looks like, what this work means, and recognize that, the really valuable, important work that community-based organizations are doing, we might not have the measures that are, picking that up or effectively sort of capturing that. And so I think that, is really part of the process, is also thinking through, like, what are the right measures for understanding community engagement and how to do that well. So I really appreciate you making that point. So thank you, Sherry and Okenfe, for the wonderful presentation. We had a couple other questions that we weren't able to get to, but we'll do our best to answer those after the webinar. And I think now we'll turn it over to Dr. Noha and hear from her about the amazing work that she's been leading at the Roots Center. Dr. Noha, if you want to take it over.
Greetings, everyone. Thank you. My name is Noha Abalada, and I'm the CEO and founder of Roots Community Health Center. I am a family physician by training, and when I finished my training in medical school and residency, I returned back to my hometown in Oakland, where I'm ready to make a difference. I began working in the safety net in Alameda County and seeing patients and doing work that I knew was really important. Yet I also recognized that the people I was most worried about were not necessarily walking in the door. And I also felt like there was never quite enough time to identify, let alone address, the underlying causes of my patients' chronic illnesses, their behavioral health challenges, really their suffering. And I was also deeply concerned you as sort of the original think tank of Roots Community Health Center. And somehow my slides are advancing without me. So I apologize for that.
Nope, sorry about that. And Dr. Nahaya, your audio cut out for just a second, but we can hear you. We can hear you again. So I'm sorry about that. We're working on it, and we'll get you back. Which slide did you want to be on here?
Focus on East Oakland disparities.
Okay, I think we're where we need to be.
Okay, with the map.
Yes, that's what we see.
Great. And so this is what we were seeing. And so at that time, we were seeing map after map that looked like this one, where primarily East Oakland neighborhoods were lighting up. And so that's sort of the darkest color there, sort of in the middle of the map. And so whether you were looking at a map of those living below 200% of poverty, like this one, or whether you were looking at number of violent crimes, emergency department use, premature death, all the maps looked the same. And we also looked at data like this on the right, and this graphic is showing life expectancy at that time. So this is back in the early 2000s. And again, just one of many similar data points that was highlighting disparities, which were particularly disturbing between African Americans in East Oakland and everyone else. And so in 2008, Roots began as a two-person mobile volunteer operation, and we really went out sort of armed with more questions than answers, and honed in on these areas in East Oakland. We started providing care right where it was needed most while seeking to understand and address the root causes of the disparities like the ones we see in this graphic. And so we really started an on-the-ground process of delivering care while listening to our patients, listening and gathering both quantitative and qualitative data, not just about barriers to accessing care, but also just barriers to overall health and well-being. And we analyze these findings in collaboration with the experts, who we consider everyone from the most impacted folks to the professionals that serve them. And so this process that lasted a little over 2 years resulted in the decision to place ourselves, at that time with just one exam room, in deep East Oakland, sort of right in the middle of this darkened area here at 99th and East 14th, kind of at the ground zero of where the need was. This process also shaped our understanding of the services that we would need to provide, and it also shaped our mission. It seems I'm not able to advance. Is someone able to advance for me? There we go. Our mission is to uplift those impacted by systemic inequities and poverty, and we do that by providing medical and behavioral health care, health navigation, workforce enterprises, housing, outreach, and advocacy. And I think the hardest part of our work is identifying, not just identifying, but addressing the root causes of illness and suffering. And we do that by emphasizing self-sufficiency and community empowerment. Next slide. So we've grown a lot since our single room in Deep East Oakland in 2011 to now having 3 state licensed clinics. One is that main original campus at 99th and East 14th, where we've expanded from 1 room to now taking about 7 suites, almost the whole building. Also our new headquarters, which is our first building purchase, where we have both our administrative offices and also a full family practice. And also Roots South Bay, which is in San Jose, and it's co-located with Ujima Adult and Family Services, which is an African-centered specialty mental health provider. We also have 3 satellite clinics. One is our Street Team Medical Outreach Clinic, or Oakland Stomp, and the other 2 are satellite clinics within drop-in shelters of youth shelters. So our Dream Youth clinics, one is for 12 to 17-year-olds and the other for 18 to 24-year-olds or transitional age youth. We also run the student health services for our local community college district, and we have our workforce apprenticeships, which are housed at our 2 enterprises, social enterprises, one that manufactures natural bath and body products, and the other that manufactures and installs signs. And so we have apprenticeships in light manufacturing, graphic design, and sign installation. And most recently, we've added some workforce and emergency housing, which is expanding, unfortunately, due to the need for housing basically being driven by our homeless crisis. Next slide. So the model that we've developed and continue to refine consists of three main components, and those are care, navigation, and empowerment. So care is just physical and behavioral health care for the lifespan. Navigation is basically life coaching from someone who's walked in your shoes. And empowerment is really providing the tools and avenues for self-sufficiency and self-advocacy, really for yourself and your family and your entire community. And so whether you're receiving healthcare at the clinic, coaching from your health navigator, or training through one of our workforce enterprises, you're going to be engaged in a manner that's authentic and ultimately informs us, Roots, as how we as an organization will develop, refine, and scale our programs and services. Next slide. And so as Roots has grown in response to the needs of our community from 2 volunteers in 2008, we're now 110 full-time employees in 2020. We've grown with our community, in our community, and of our community. So we reflect our community, as this slide shows, both in terms of race, ethnicity, and as well as gender. And because we're really intentional about hiring, training, and supporting folks from the community to do this work, we also reflect the community in terms of life experience. And this is a really big part of what makes Roots so organically responsive to the needs of our community, because we are the community. So this is a little different than having sort of a separate class of peer mentors or volunteer ambassadors, although those also definitely serve a role. But for us, we have certain roles like outreach specialists or navigators where we consider life experiences that reflect those of our community, like history of incarceration or homelessness or foster care, as actual job qualifications in the hiring process. But once hired, these are full-time paid staff who are fully integrated and indistinguishable from and with the same opportunities as anyone else at Roots. So you'll find folks with all kinds of lived experience as program coordinators, managers, administrators, all of whom participate in the design, implementation, analysis, and improvement of our programs and services. Next slide. And these staff are critical in enacting a key component of our work, which is meeting people where they're at. And so this is both literally in terms of where they are, like encampments or on the streets or in jail, but also figuratively in terms of people's state of readiness to change their own trajectory. Next slide. So we meet them with culturally congruent providers and staff, providing care and resources at the time and place of need. So from benefits enrollment to clinical care in our facilities or in the streets to the distribution of food and basic supplies. We're working with folks that are the most impacted. And as we're doing that, we're asking pertinent questions and refining our individual services accordingly. And that in turn is informing our community level interventions. And so this is an iterative process that's kind of baked into our DNA. And it's really never done because as conditions evolve and change, like with our emerging homelessness crisis, we also have to evolve and change. Next slide. And so this iterative process begins with what we call authentic engagement. And like I described earlier, this is really how Roots began, so with more questions than answers. And so from those early days going directly to who was experiencing the disparities, we confirmed that one of the greatest barriers to health and well-being for our community was poverty itself. And especially for many of the men in our community, they were facing being unstably housed and unemployed, and their most frequent barriers were barriers to employment. And we found, and this is back in 2008, that these were often due to a history of incarceration. And so before it was really called reentry and before there were special funding for this, we were already implementing navigation and care management services for post-prison release as a complement to the clinical care that they were receiving in our clinic. And so our providers and our navigators, as they engage with their patients and clients, are helping to surface findings regarding barriers to good health, and then we go deeper. And we have several different methodologies to do this, like the think tank I described earlier that reviewed community data, which evolved to also look at our own patient data, both quantitative and qualitative, to further focus our efforts and refine our questions. So kind of in that fashion, we were adding and refining questions in our assessment and reassessment process. And many of these questions are now things that we're referring to as social determinants of health questions, but really to help shape our interventions at an individual level. And then we don't stop there. We go further. So when findings come out of all that data and all the work that we're doing with individuals, we might conduct targeted interviews with patients or with the Root staff who are serving them, or with systems leaders and other stakeholders to better shape our understandings and what some potential interventions might look like. We might conduct focus groups or implement surveys to go deeper on any given topic. One of our favorite venues, I think, are listening sessions, and so this is where we engage community a little more broadly, share our data, and hold an open forum to help surface solutions. And all of these methods, I think, help us ensure that we're asking the right questions and that we're contextualizing our data appropriately. And I think this is a really important piece to emphasize. We think that data can actually be a weapon in the wrong hands. And so whether it's intentional or unintentional, we know that having the appropriate context and interpretation of data is how we're going to get the right intervention, and how we're going to prevent doing more harm than good. And especially in the case of we're talking about our most marginalized populations, we have to be really conscientious to ensure that we do no harm in this process. And so the picture on the top right there is of a reentry leadership development fellowship that we designed in order to be able to go deeper on some of these topics while kind of creating a supportive and safe environment. Because we're asking people to tell their story, to talk about some of the most challenging things that they've been through, and to advocate for change within some of the systems that are making decisions on their behalf. So this was a 6-month fellowship that actually included training on storytelling and recognizing and managing your own triggers, and really sort of supporting these folks in terms of their civic engagement. And these fellows actually ended up holding several community forums and listening sessions where they invited community members and their families, as well as police officers and even the chief of probation, to be able to hear solutions coming directly from the community. Next slide. And so from sort of our doctors in the exam rooms to the navigators doing their coaching work to the reentry fellows conducting listening sessions, and we're collecting all this respective data from each of these venues, and we're analyzing and identifying themes and trends. And a lot emerged from that and continues to emerge. And so one specific example was actually regarding housing status and of those who are sort of leaving incarceration. And so out of the hundreds of people that we were navigating, we'd always been asking about their housing status, but we realized that the way we were asking the question was not sort of capturing the whole story. And so what we knew was that about half of the folks that we were navigating after their release from incarceration were literally unhoused. But what we didn't know was some of this nuanced information that you see here on the left, which let us know that another 35% or so were very unstably housed or in a type of shelter that was going to be imminently ending. And so much of this information actually came from feedback from our navigators, and then we further dove into it with the reentry fellows in terms of their listening sessions and asking more specific questions around what kind of housing challenges and situations they were in after coming home from incarceration. And so by refining the question in our intake process and our reassessment process, we've had a much better understanding of how to, I think, not only help sort of the person right in front of us, but also it has informed our broader interventions that we know we need to implement sort of on a community level, and I'll share some of those with you in a moment. One of the other outputs from the fellowship was a toolkit that was co-created by Root staff and the fellows, and this contains recommendations that we've continued to follow and build upon. And then we also share with others, including leaders in the community that are making decisions on behalf of this population, who've also provided the feedback that this has been valuable in terms of them sort of shaping their responses as well. Next slide. So here are a few of the interventions that have come out of the process that I described, which is, again, sort of hiring from the community, meeting people where they're at, and providing the services that they need, authentically engaging as a means to refine and expand those services. So our Empowerment Center, which is over there on the right, is a no-barrier space where folks can come in and do job search, develop their resume, get access to jobs and hiring fairs, which is there on the lower left, one of our hiring fairs with employers, many of whom we know that they're reentry friendly or we know that they're not, and so we can effectively manage expectations. Our Oakland Homecoming program, which is on the top left there, is actually housing for those who are engaged in our apprenticeship programs who are unhoused. And again, much of the need for this was really surfaced from us getting a more nuanced understanding of the housing situation of folks when they're coming out. And our Clean 360 social enterprise there, which provides on-the-job training and light manufacturing for those with the highest barriers to employment, came directly out of our think tank work and sort of surfacing the fact that the folks with high barriers to employment, that was really their biggest barrier to health and well-being. And so even though this example is with the reentry population, we really see that this methodology is easily applied to any population or a community or even just a subgroup about whom we're really worried. But I hope, as I've illustrated, that it really has to start with a very deep understanding of the population you're trying to impact, which we believe only happens when they're included in every step of the way. Next slide. And I wanted to say that I think this whole iterative process is important not only to identify gaps and barriers, but also to identify strengths that we can build on. And so a few examples of that. Our Dream Youth Clinics, those were developed to identify or to fill a gap that we identified in access for vulnerable youth. And so these are including young people that are disconnected from school, that are homeless, that are sexually trafficked, that have been perhaps part of the foster system for most of their life. And so these clinics are intentionally located within drop-in centers where the young people gather. And so our Dream Youth Clinics were actually named by the youth, and they're really youth-led, youth-designed spaces that are adult-supported, but they really build upon the resiliency of our young people. Another response to the data that we've gathered on what we would call protective factors is that our patients often cited just being at Roots. It was important for them to feel like they were family, to see people and be around people that look like them, that have experienced what they've experienced, really to feel like they were within community. And we also knew from our intake process that food insecurity was an issue that was not always completely mitigated by enrolling folks in CalFresh or food stamps. So we helped address sort of this identified need of food insecurity by building upon this identified strength of us having sort of an anchor space within the community. And so we created a central courtyard in the middle of our building. We put in raised beds where we grow food, and we hold pop-up markets, and we serve weekly hot meals. And this has really become such a positive, healing, gathering space that is truly, an asset that our community has come to rely upon. Next slide. And I think our work sort of with individuals as patients through the lifespan has also underscored for us the need to engage with families in whatever configuration they may be, so that we're part of modeling positive and affirming sort of relationships and spaces and interactions. And so we've developed play groups and motherhood circles and fatherhood groups and family engagement activities that sort of have helped us create that through line from working with individuals to family to community. Last slide. And this is our Growing Roots family, and that concludes my presentation. Thank you.
That's terrific. Thank you so much, Dr. Noha. And just every time I hear you talk about your work at the Roots Center, it's so exciting. You're doing wonderful work over there. So we are at the Q&A portion of this presentation. We've got a number of questions that have already come through. If folks have additional questions, please use the Q&A feature. So I'll dive into some of the ones that we've gotten so far. One question was around whether or not you had collaborated with any health plans in any of these efforts, and if so, what does that look like? Are there any outcomes that you could share from that experience?
So we are, active kind of providers for both the whole person care pilots and also with health homes. And so I would say that, most of the collaborations with the health plans have certainly been in those complex care spaces. We have definitely sort of data on utilization around reducing emergency department and hospitalization bed days, particularly in Santa Clara County. where, we see that our wraparound approach is definitely helping to keep folks out of the hospital. And I think, from our side, definitely seeing the more appropriate utilization in terms of having a place to feel comfortable coming to and knowing that all your needs will be met sort of before you might hit the emergency room. And so a lot of it was sort of developing that relationship that folks had never really had in primary care to sort of cause sort of more appropriate healthcare utilization. And so I would say that's probably the best area where we have good data from the health plans kind of affirming the approach. And I would say that for us, becoming a community-based care management entity or participating in these pilots was not really a shift at all for us with our work. And so it has really lent itself to the fact that we began with sort of this navigation model and having a person that has similar lived experience, being able to help you navigate systems. But I think more importantly, the coaching framework of what are your goals and how can I help you achieve those, because your goal right at this moment might not be, that colonoscopy or, about the emergency room. It might be about being reunified with your child or, gaining custody of your child or becoming housed. And so I think the model was easily translated for us into complex care, and we really look forward to seeing, I think, the larger systems recognize that this is a model that should be applied to folks before they find themselves in that situation of needing complex care.
Mm-hmm. That's great. Thank you. So another question just came in from somebody who was really impressed with the demographic slide that you showed, where your staff demographics very closely mirror the demographics of your community. And the question is, a couple questions here. One is, did you start out with that level of equity, or did you have to invest over time to get there? And what did you take to make sure that you had that equity or that mirroring of the similarities between the makeup of your staff and your patient population in your community?
So it definitely started out very organically, and I think has continued that way in terms of people who sort of want to be involved with this mission of improving the health and well-being of your own community. And so when we began with the 2 volunteers and we grew ultimately to 6 volunteers before hiring our first employee, all were literally from the community, had walked past, had seen it, and just got intrigued and excited about the prospects. And it's continue to grow that way, where I think particularly for providers who want to work in community and really be a part of seeing that their patients' lives are being transformed. And so we've become a little bit of a beacon for, I think, particularly providers of color, providers from the community who really want to be back in their communities. And same with sort of every, I think, level of involvement. I think the biggest challenge that we ended up facing, that was just one of those pieces of the reality of the challenges of hiring from the community, really was around the formerly incarcerated status. And so I would say at any given time among our staff, probably 25 to 30% of our staff have, something in their background. It doesn't have to be the job allocation for the job they have per se, but it's nevertheless a reality. And I know this is challenging, especially for larger systems, and for us it's challenging too. We've had to build up quite a bit of infrastructure to be able to do the appropriate level of screening and also provide the appropriate level of support to staff that we hire. But we have sort of made that commitment and made that investment in an effort to be able to maintain this goal of having a staff that's really reflective of the community we serve. So it's certainly not easy in a sense. But on the other hand, I think it has been very natural and organic that the folks that seem to be attracted to Roots are the people who really, feel like they're making a difference in their own community.
Mm-hmm. That's great. Can you actually speak a little bit more to some of the ways that you guys have thought about investing in supporting your staff, given some of the unique just aspects of recruiting so directly from the community, or having the community members so strongly reflected in your staff?
Absolutely. I think it's one of the most important things that we do because, as we know, our staff are, because they're not only from the community, but they're working so deeply with community, they are definitely prone to experiencing sort of vicarious trauma and the stress or burnout that comes along with this type of work. And so, and not only that, I think we're asking people to bring their life experience to work. And so I often kind of remind people, if you were asked to kind of have some of the toughest times of your life, be at the surface of your work and how you're engaging with folks, and that's a lot to ask of somebody. So we try to be very mindful that we are asking a lot, especially of our staff who have lived experience as part of their job requirements. So if you're a reentry navigator, you have a panel of 40 people coming out of incarceration, you're formerly incarcerated as well, and so it can be triggering. So we do quite a bit of training. We actually do quarterly trainings, refreshers around, identifying and managing your own triggers, de-escalation techniques, how to basically, care for yourself, and, appropriate boundaries, transference and countertransference, or all of those things that I think, go with a curriculum around health coaching and community health outreach work. But this is something that we've really sort of embedded and do continuously because all of us who are caregivers know that we tend to put the needs of the folks we're serving before our own. And so this is a really key part of, I think, the training and the support that we provide. Also sort of making, open space for our behavioral health providers to be very integrated into not only primary care but also into navigation so that our behavioral providers are actually accessible. They sit in on the various groups that we hold, the different education sessions. They help observe. They help us make sure that we don't have any staff that are burning out. They do a lot of wellness activities with our staff, and I think this is a really critical piece, not only to support our staff, but also to really destigmatize behavioral health services in our community where behavioral health has a huge stigma associated with it. And so by having our navigators have really great access to our behavioral providers, they're able to also encourage their clients to avail themselves of behavioral health services as well. And I'd say lastly is that we're very mindful of people's job duties and descriptions, and we make sure that for certain job roles that are very intense, that those folks are rotating more. And so it may be that their job is split between being in encampment and being at our main site, for example, or that they're rotating through the different sites on a more regular basis based on the exposure that we know that they're having for that type of work. And so even as we're crafting the job descriptions, we try to be very mindful that we're able to support folks and that they can have a good balance.
Well, that's incredible. Thank you. So you guys are clearly so thoughtful about all that. It's really wonderful to hear how you're approaching that. So another question has come in around the listening sessions that you talked about, and this person was curious about how you recruit community members for the listening sessions and how you facilitate them.
Sure. So it really depends on sort of what it's about. We've had many of them. The one that I described earlier, we actually had the fellows. Part of their training through the fellowship was learning how to recruit and do outreach and also to facilitate. So the fellows actually facilitated those sessions. We've done others. One of the more recent ones we did was actually when our city passed the soda tax, we became aware that our geographic area not only voted against the tax, but also was sort of suffering some of the highest rates of diabetes and other sort of sugar-related issues. And so we did a whole campaign, and that included door knocking. And so through the door knocking, we were wanting to surface what did people want to see this tax spent on, and how could we ensure that there would be equity in the distribution of those tax resources. And so not only did we end up sort of mobilizing a base of folks who were aware of the tax, who were able to respond when the tax almost went into the general fund and stop that from happening and actually get it to be allocated in part based on the disparities that we saw. But when it came time for the listening session, we already had sort of this group of people within the community who we had met through the door knocking process who also recruited additional people. So it can be anything from recruiting through our partners, passing out flyers, knocking on doors, social media, navigators telling all of their clients. And sometimes if we really need a very targeted or specific group of folks, like occasionally will happen where we want to do a focus group on something more targeted or even a listening session on something more targeted, we also will mine our own data and do in-reach. So based on we need people who are currently on probation or parole, we may go ahead and mine our own data and do in-reach and make phone calls to, the navigators will actually call the clients and ask them to come in as well and bring a family member, for example. So it really depends on the topic, but we have a number of methodologies to bring in either as focused or as wide of a cross-section as we need for that particular topic.
That's great. Thank you. So I think we have time maybe for one more question, maybe two, depending on how quickly we can get through this one. But there was a question about going back to this idea of how we measure this work or measure some of these cross-sector health challenges. And so this person is curious about, what do the community members have to say about what we should be measuring to better understand health quality or equity? And then I'm curious if you guys have ever done anything within Roots around co-design for measurement or understanding, thinking about ways to pull in the community voice into developing measures.
Yes, so this is something we actually almost always do. And so whenever we are designing a new program, we are asking both within our staff as well as within our patients or clients who should be at the table as we sort of define what success would look like. And so, for example, we're about to launch pilot at Santa Rita Jail in the parking lot when people are released overnight so that they have a place to come and be safe and eat and drink and engage in services. And we had our visioning session, which is how we typically do this when we have a new program coming, and about half of the people sitting at that table had been incarcerated at Santa Rita Jail. And so they were a part of, just as valuable as a voice as anybody else at the table that's, involved in design and implementation. As we developed our results-based accountability framework, it really starts with what would success look like, and what are the things we need to get there, and what are the things we would need to measure to demonstrate that we're getting there. So this is truly how we do our processes in general. So whenever we can, we've got folks from the community with that lived experience, and oftentimes they are people on our staff, so that's a bit of the luxury of hiring from the community, is that oftentimes you do have impacted community members also already on staff, but that's not always the case. And so we do make an effort within the co-design, and then again, as we analyze how we're doing. And so again, we want to make sure that when we're looking at the data, that we're not just interpreting it in our offices with our best ideas, but that we actually have people at the table who can give us a lot more, I think, nuanced understanding of what it is that we're seeing and then what we could do to overcome that.
That's great. I'm going to squeeze one more question in here, which is if you could say a little bit more about how you partner with community-based organizations. And one of the questions that came in specifically was whether you've ever contracted with them or considered contracting with community-based organizations to actually be part of your navigator staff or sort of serve that function.
So we actually do quite a bit of subcontracting with community-based organizations for different functions. One of them is Healthy Black Families. For example, they work specifically with Black mothers, and we're part of Black Infant Health in the city of Berkeley, and we really felt they had an area of expertise in working with mothers that we wanted to partner with. And so, for example, we will include them if we are doing specific projects that are targeted towards moms, and we always build in a way that we can sort of cross-pollinate, where we're helping build their capacity in an area and they're helping build our capacity in the area. That's generally how we work with other community-based organizations, is that we sort of come from a position of we're not going to do this work by ourselves. Not only can we not do it all ourselves, we shouldn't do it all ourselves, and so we need to partner with folks who are mission aligned and really see how we can all harness kind of the best of what we bring to really impact a situation. And so we have subcontractors and also fiscally sponsored organizations. So they may not even, they may not be a nonprofit. It may be a community group like the Sobrani Park Resident Action Council, where they're fiscal sponsor. They're community members, residents who formed a resident group, and they advocate for issues that their community needs, and we're able to support them and provide a little bit of sort of backbone infrastructure and also help them build capacity. So I think for us, every funding opportunity or contracting opportunity, one of the first questions we always ask is, are subcontracts allowed? And if they are, we find the best partner to be able to help us, sort of do better in a particular focus area. For us, when it comes to navigators, they're all sort of on our staff. They're actually almost half of our staff. But I can see, that potentially being able to work, especially with a particular focus group, is, to subcontract. And we do this sometimes when, also when we don't have language capacity, let's say. And we have an organization that we partner with in the South Bay that has several African languages, language capacity. And so we've also looked to them to help serve a role when we don't have language capacity. And so I think those partnerships are really, really critical and something that we consider kind of core to the work we do.
That's wonderful. Well, we are almost at time, so I want to extend just a sincere thank you to Dr. Noha at the Roots Community Center and Sherry and Okente at Maimonides for the wonderful presentations that they gave. Thank you again to the Robert Wood Johnson Foundation for making this webinar possible. And just very quickly before we wrap, I want to touch on two resources that might be helpful for those of you who are looking to dig in deeper on strategies to improve care for individuals with complex health and social needs. The first one you see here is our website, which has a bunch of resources. You can subscribe for updates, or you can follow CHCS on Twitter to stay up to date. As I mentioned, we've put up a lot of material from our projects focusing on this topic of community engagement, so I encourage you all to peruse that. And then second of all, you can also browse the playbook for a rich set of practical tools and promising care models. And I want to put in a plug that we're looking for your good ideas. So if those of you on the line have any promising practices to share or published materials on a complex care program, we'd welcome you to submit your resources or ideas to the Better Care Playbook by clicking on the Submit a Resource button on the Playbook homepage at bettercareplaybook.org. So thank you to everybody on the line for joining and taking time out of your day to listen to the webinar. Thank you again to Roots and Maimonides and the Robert Wood Johnson Foundation, and we appreciate everybody's time. Thanks and take care. Have a good day.